Greetings all and welcome to this video podcast on an important topic about you, your genes and your genomics. You know, where have we come from and where are we going? And I think with regard to prostate cancer, you know, the link between your genetics and prostate cancer risk is well documented, but it's not so well understood, with between 5 and 10% of men diagnosed with prostate cancer having some form of genetic link. So welcome again. Jeff Dunn is my name. I'm the Chief of Mission at the Prostate Cancer Foundation of Australia, and it's my pleasure, my absolute pleasure, to walk you through this video podcast that we're recording here today. And I'm joined by three superstars, all eminent in their own way. And first up, can I introduce Associate Professor Shahneen Sandhu, a medical oncologist and researcher at Peter Mac. And of course, Peter MacCallum is one of our premier research institutes. And Shahneen's been involved in looking at novel therapeutic interventions for treatment of prostate cancer, and is interested in biologically driven clinical trials to make sure that research gets translated to the bedside to improve outcomes for all of us. Along with two survivors who have genes associated with prostate cancer. Will McDonald, who, if you're in South Australia, you all know Will, because he presents the news to you every night, and because Channel 9, of course. But he'll tell you about his own story, but Will's a great supporter of the Prostate Cancer Foundation of Australia and in raising awareness. And certainly, with regard to genetics and prostate cancer, has a particular interest. And Andrei Norris, again, who is a gene-carrying survivor. And Andrei hails from Tasmania. He is a father like Will. He has variations of a well-known gene mutation. He will once again talk about that. And Andrei, as well, has been very much involved with the Prostate Cancer Foundation of Australia in helping us advocate for changes necessary, for research that's required, and to raise awareness of this very important topic. But without further ado, why don't we then turn to panelists and see if we can get this video podcast started. And perhaps Shahneen, I might come to you first, if that's okay. And Can you just tell us a bit about, genes and prostate cancer? Where have we come from? What looks exciting in the future? How do you assess the state of play?
Thanks, Jeff. It's a delight to be part of this program, and it's such a critical program to raise awareness about the importance of genetics in prostate cancer, in particular, given we've now got some really good treatments for a subset of men with prostate cancer. So where have we come from? We've known for a very long time, as you alluded to in your introduction, that in fact, prostate cancer is probably one of the most inherited cancers, but our understanding of some of these genes that predispose patients to getting prostate cancer is evolving. And there are a number of different ways to think about it. There is genes that cumulatively cause a risk for an individual, but then there are genes like, in particular, the BRCA1 and BRCA2 gene, which are what we call high penetrance genes, where if you are a carrier of one of these genes, then you are certainly at more risk of getting prostate cancer. Where we have understood since probably 2015, really, our understanding started to shift. We knew for a little while that BRCA1 and BRCA2 genes ran in families with breast cancer and ovarian cancer, with, I think, Angelina Jolie making the BRCA1 gene very famous, given her mother had breast cancer and her mother had ovarian cancer, and her grandmother had ovarian cancer. And as a consequence, she took some prophylactic measures. And so she shed a lot of light on some of these genes for women with breast cancer and ovarian cancer. And so it's been known for a long time that these genes run in families with breast cancer and ovarian cancer, but also they were found in in families who had prostate cancer as well. So we did know that, but what we didn't appreciate for a long time until about 2015 was actually the incidence was actually much higher than we had previously anticipated. So in 2015, there was a number of clinical trials. One I was involved with when I was working in the UK doing some research, where we found that the incidence of BRCA1 or BRCA2 genes was approximately 10%. So it's quite high. It's 1 in 10 men walking in your door in the clinic, seeing us in the clinic, actually will have one of these alterations in one of these BRCA1 or BRCA2 genes. It's predominantly BRCA2 rather than BRCA1, but the incidence is 10%. And the other point that I just want to make clearly is that out of that 10% of men that have these alterations, 50% or half will be something that has changed within the tumor, so that the cancer has evolved and changed, and as a consequence, there has been one of these genetic changes within one of these BRCA genes that helps to promote the cancer growth. And in 50% of the men, it is actually it is something that they've inherited from either their mother or their father. And what's quite interesting as well, that we've learned that unlike breast cancer and ovarian cancer, where the family history can be a little bit more glaring, the patients can be younger. In prostate cancer patients, we find that there isn't any obvious clinical features that would point the clinician to say, you've got a really high risk of having one of these genes. So the bottom line, I would say one of the key important bits of information we've learned is that 10% of men with advanced prostate cancer will have a BRCA1 or a BRCA2 genetic change, half of which is not inherited and half of which is inherited. And the reason that's really important is twofold. One, we now have effective therapy for those patients that have got these genetic changes. And this therapy is called olaparib or Lynparza, and it's a tablet, and it works well, and it's been shown to improve, control the disease, improve quality of life and survival. So it's important for the individual patient to know that their tumor has got this genetic change, and that the doctor can use this information to inform the sort of treatment and care the patient gets. The second reason it's really important that men with prostate cancer speak to their doctors about getting these tests done is on the off chance they happen to be that 50% or out of that 10% I said, 1 in 10 men, half of them will be inherited. If it is indeed inherited, then those patients are in some ways acting as a whistleblower for understanding that these genes run in their families. And as a consequence, it may have an implication for their daughters or their sons. So these are the two reasons why getting these sorts of tests in the clinic is so important.
Thanks, Shahneen. I appreciate that. I'm wondering whether just a question now, can you just explore a little bit about cost and access? So just for those people listening and watching us, just about access and cost, because there has been some confusion about that. Are you able to help us out with that?
Yeah, so we're really fortunate that in Australia, for the first time, in fact, for the first time in prostate cancer, we've got a personalized therapy. By that I mean you identify the genetic change and there's a treatment that's linked to it. So this is the first time it's happened for prostate cancer. And we're so fortunate in this country that the funding, we've now got funding for genomic testing for men with prostate cancer, which didn't exist 2 years ago or even 12 months ago. So it's a recent thing. And so in fact, there is no cost to the patient to get genetic testing. and it can be done in a number of different laboratories. I think as time goes on, the access to this testing is going to be more widely available as different molecular laboratories start to do it. But at present time, there are a sufficient number of laboratories that your medical oncologist can send off, a sample to get tested. The additional point I want to make is sometimes patients are confused. They feel they don't want to get the test done because it might involve additional tumor samples or, the doctor wanting another biopsy, which could be horrifying for the patient if they've had a terrible biopsy the first time round. But in fact, you can get good results from the original biopsy that made your original diagnosis of prostate cancer. So in fact, there's very little you need to do as a patient other than raise it with your clinician.
Okay. Well, I mean, isn't it terrific to see that there's been that progress here and that testing is now recognised as being important care? Just one other quick question before we perhaps talk to Will, was more about, we spoke a bit about, the BRCA mutations, and you mentioned those. I mean, just other genetic variations or mutations. Are there any others in particular that you would raise in this discussion?
So I think when you are having a genetic test, it's important that your doctor explains the implications of a genetic test. And I always give a very simple explanation in that you can get what we call driver mutations or driver changes, and you can get things that are passenger mutations. So sometimes you get mutations that are driving the cancer, and sometimes they are mutations which we don't really know what they mean. We use a terminology called variants of unknown significance, and it's unknown significance because we just don't know what it means at present time. So broadly speaking, when you do a genetic test, you can get a range of results. But the key ones where there are implications for patients, I think the major ones that there are implications for patients are BRCA1 and BRCA2, where there are implications from a therapy perspective for patients, and also potentially from a family perspective, if in fact, when you do the tumor testing, they find that they then have to do a genetic testing to find out whether it's also running in the family. So that's got implications. One gene that I haven't touched on, and I do hope that in time we get to do this genetic test a bit more, because there is also a therapy linked to it, is mismatch repair. So mismatch repair is another gene that is, it's a group of genes that make the cancer more likely to do the repair job particularly abnormally. And as a consequence, those cancers essentially have got a very high chance of responding to immunotherapy. The incidence of those genetic changes in prostate cancer men is low. It's thought to be between 1% to slightly under 5%. That's what the literature suggests. And unfortunately, at present time, we don't have funding to do that test. But that's another important genetic test, that if a patient had one of these alterations, then there are significant implications from a therapy perspective for that individual patient. So my approach in the clinic is, if a patient can afford genetic testing for a broad range of genes, then we might do a broad panel that covers that gene. If they can't afford it, because the chances of finding those alterations are very low, then in fact, I'll go down the track of doing the BRCA1 and BRCA2, which is funded and is linked to a therapy. Yep. Yeah. There are other genes like HOXB13 and other genes as well that are inherited, that confer an increased risk for family members to. It's a gene that is linked to prostate cancer, and therefore a slightly increased risk of other members getting prostate cancer.
Hey, look, Shahneen, thank you for that. And I, do appreciate on behalf of those listening. I mean, it is terrific to see the progress and the product of the research. We're seeing We're seeing developments and, improved outcomes, but there's still a long way to go. And with that, I might throw to you, Will. I mean, from your perspective, Will, your own experience, what it means for your life, what it means for your family. Just talk us through that.
Yeah, look, just very briefly and quickly, my diagnosis happened in July 2020. I was 42 years old. At the time, I'll be honest with you, I thought I was bulletproof, except for what I had was my left hip joint was disintegrating, essentially, and I didn't understand why. Turns out it was metastatic prostate cancer. After an MRI, I discovered that was probably the issue that came about. So I went through my chemo, radiotherapy, I'm on hormone therapy. But what I did really early on in my treatment was that really high level gene testing on my biopsy. And back then, there was nothing covered. At least I wasn't told it was covered, and it cost me $4,000 to get it done. I was in a situation where I could pay the money, but there was still a lot of money for me and my family. But I didn't want to leave any stone unturned. So I had that genetic testing done on my biopsy. It came back with what I understand would be a lot of unknown significance. There was some mutations in there, but they didn't really know what was going on. Shahneen mentioned it, and it's something I've never heard of before, but I went to the SA Health genetic testing clinic under the advice of my oncologist, and we did a range of blood tests then. And I came back with the HOXB13 genetic mutation, which is obviously what I know now means that I'm got a much higher chance of prostate cancer, tick, and I had a much higher chance of getting prostate cancer when I was younger, tick. So I kind of got hit with that one. For me, what it means for me now is just absolute vigilance for the younger males in my family. And I can hear him crying at the moment, but I have a 12-week-old son, Alfie. And I'll be honest with you, we went through IVF to get him because I was obviously my treatment left me infertile. When I heard he was a boy, I did, be honest with you, I had this moment when I went, oh, for F's sake, because I knew what gene I was carrying and I knew what that potentially meant for him. So my whole focus now is making sure people know their risk, and especially making sure Alfie knows his risk of prostate cancer. And fortunately, he will. So he won't have to worry about getting diagnosed at the stage that I was diagnosed. Hopefully, he's never diagnosed. Hopefully, we've got a treatment in 30 or 40 years' time, which means he never has to worry about it. But just knowing that at least he can be far more aware of his risk, it means everything to me that he's not going to have to go through the same stuff I went through.
I mean, it is a tough one, isn't it, for parents, knowing this?
You feel guilty, Jeff. I'll be honest with you. There's a level of guilt, and I've spoken to my brother about this, and he's ultra vigilant with his PSA testing. He's just a little bit older than me. My dad had prostate cancer when he was 75. He fortunately caught it fairly early because his GP was on top of all that stuff, and he's fine and tickety-boo now. He went through the operation and came out of it really well, and would be cancer-free. But yeah, now I'll be honest with you, my dad would probably feel guilty. I feel guilty that I've got this genetic mutation, which is potentially going to affect my son. But knowledge is the power that we now have. So I feel far more relieved that's out there and we know. And that's why I think genetic testing in whatever ways we can do it and whatever information it gives us, I think is so vital. And you never know what treatments are going to crop up into the future. There's a whole list of things on my biopsy, which is unknown significance. Hopefully there's a known significance at some point in the future.
Well, that's right. Shahneen mentioned some of those earlier. Well, tell me, is it folklore or is it fact that, I mean, were you and your dad diagnosed about the same time? Is that correct?
Yeah, it was not quite the same time. I reckon Dad was December 2019 and I was July 2020. So just 6 months shy of each other. I slipped through the cracks, to be honest with you, in terms of knowing my family history, and I just want to make sure no one else. I didn't understand. I never thought at 42. I thought I'm not going to get prostate cancer yet. Yeah, do that later. And it wasn't even a thought like that, to be honest with you. It didn't even really cross my mind. And it never kind of came up. But yeah, 6 months later, whack. So yeah, I slip through the cracks, like I say, and I just want to make sure no one else does.
Well, I mean, you quote knowledge is power, and understanding that and trying to get that awareness out there. That's certainly what's making the difference. I mean, you mentioned Alfie, and what a great kid.
He is a great kid. He sleeps quickly. He sleeps about 8 hours a night, and he's only 12 weeks old. So we're very, very lucky. But no, he's an absolute blessing for us. And I like to use him as the example that there are no average prostate cancer patients. I was 42 when I was diagnosed, and I now am a father for the first time 3 years on. So that's not average. No one was average. I think everyone needs to know their own risk and get as much information about whatever is going on in their family history and genetic lines as possible to help make sure they don't end up in a worse situation, or at least one they can avoid. Well,
it's true. And, you raise an important point for all of us in terms of the impact, that psychosocial impact, that, the realization of a gene-affected prostate cancer and what that means for family. And I think there is that additional burden. And these are things that we do need to be aware of for some. And it does change the way you think about things, I'm sure. And certainly, in terms of vigilance with regard to family members, that would be uppermost, I think, in your mind.
Yeah. I just honestly, I think at least now there's a benefit from me going through it, that people will know that the younger males in my family will have to be a bit more vigilant about stuff. So at least there's always a positive.
That's right. Well, that's right. And that's the way you look at the world, though. I've seen that in action. So it's terrific. Will, we might give you a break, and we might turn to Andrei for a moment. Now, Andrei, Will's been talking about his experience. You've had advanced cancer now for 6 years. And once again, it's a genetically impacted cancer. Can you just talk to us about your experience, Andrei, for the moment?
Thanks, Jeff, and thanks, Will. Some really insightful points there. There's certainly some commonalities and some differences between my story and Will's. So I was diagnosed at a relatively young age, not as young as Will, at 45 with advanced and aggressive, or locally advanced and aggressive prostate cancer. Prostate cancer was on my radar because my father was diagnosed. So I was diagnosed in 2017. My dad was diagnosed in 2006. With prostate cancer at 61. So I knew that I had a risk of prostate cancer. I understood that there was quite a significant hereditary risk. So it was well and truly on my radar. My dad was being tested, so he was caught early, treated, and, 16, 17 years down the track, he's living a happy retirement, and he's been cancer-free for the entire time since his treatment. So my story is a little bit different. My cancer, which completely confounded me because I was aware of it, came early. So I was 45, my dad's 61. Figure that out. Because people think of prostate cancer as an older man's disease. So there is a little bit of a myth around that. Obviously, there's an average, but it can affect men, at a much younger age. And just because your dad gets it at a certain age, and Will's reiterated this too through his story, it doesn't mean you can't get it sort of dramatically earlier. And that's certainly where I got caught out. So my first regular screening test was at 45, and that was actually when I was diagnosed. I had been in at 40 because I was aware of this thing, and I sort of thought, it's like breast cancer. You go in at 40 and testing starts then. But in fact, testing or regular testing wasn't recommended for me with my family history until 45. So that's when I, went in for my next test. I had some unusual things going on a couple of years out from my test, and I just sort of dismissed them. None of the classic symptoms. But in any event, it was quite a surprise and a shock to be diagnosed at that point. Now, my understanding is, and I'm not sure if my dad's tumour has ever been tested, but my understanding is he doesn't carry any of these genetic risks that we're aware of, whereas I do. When I had my tumour tested, it was positive for a somatic mutation, which has occurred somewhere along the line. I was tested for familial BRCA, but I was negative for that. It was only when I had a recurrence further down the track that my oncologist thought, hey, this cancer is particularly aggressive. Maybe we should look at the tumour tissue itself, or look at whether there's been a somatic mutation, and that was positive. So obviously it didn't, I was never in a position to inform my risk, but what it has done is inform my treatment. And, obviously we have treatments now, or a particular treatment for BRCA mutated prostate cancer. So at a point in time, I may well be a candidate for that.
Well, that's right. I mean, can you just explain for those listening just about the difference in the types of BRCA? Because I think, you've mentioned the one you got, somatic BRCA. So that's something that's happened in the tumour itself, as opposed to something that was passed to you by a family member.
Yeah. So, I don't have any inherited BRCA mutation. So that means that, mine has developed sort of spontaneously, if you like. That's how I explain it. And I sort of understand it as that's what's led to my cancer occurring, or perhaps it's, something that's occurred in the cancer process. I think Shahneen was talking about that earlier. But what it does mean is that because I don't carry a familial line of BRCA, I don't pass it on to my children, which is, different to Will's situation with the mutation that he has. But for me, a tremendous relief because my daughters won't inherit that risk. It's something that only I carry. So that's a significant reassurance for the rest of my family in that regard. Yes,
well, I can understand, how that would be, particularly listening to what you've talked with us about, and then, real circumstance where it is something which is genetically passed through. Can I just, Shahneen, if I could just come to you there, just picking up some points that Andrei's made. So the BRCA, the somatic variety, the variety that develops in the tumour itself or in the body itself, not passed down from, family member to family member, is that, is it more implicated in developing a prostate cancer, or is it more involved in making it more aggressive, or is it a bit of both, or it just depends? Or
so great question, Jeff. So it probably is a bit of both, or depends, and it's an area that we don't fully appreciate it. But just to touch on a couple of points that both Will and Andrei raised. So I suppose the one thing, I observe in the clinic when I talk to patients about testing is one of the things I always broach is the implications to family members, because of course it's not something, this whole idea of genetic testing is very new for patients. And so I use that as a conversation for a bit of education about, when the gene is inherited versus, and the implications of that versus when the gene is actually occurring within the tumor itself. And a simple way to think about it is that we all inherit 2 copies of every gene. We inherit 1 copy from mom and 1 copy from dad. And your tumor has also, cancers essentially arose from a cell that was part of us that just went haywire. And then as it went haywire, it kept acquiring different things along the way. And if somebody, so you can either inherit a bad copy of that gene because mom or dad had a bad copy of that gene and they've passed it on, in which case all your cells have one of that bad copy. And then something has happened in the cancer where another gene the second gene has become mutated or changed or altered along the way. And then that promotes the cancer process. Right. So that's when you've inherited a bad copy and something else happens to the other good copy that was in the tumor itself or in that cell. In the case where you have inherited good copies, a good copy from mom and a good copy from dad, but then what's happened along the way is this cancer of this cell that has decided it's going to go haywire. It started to change and alter and mutate. Along the way, one of the genes that gets altered is this BRCA gene. And that's helpful to the cancer because the gene itself is involved in repairing DNA damage. And so if you've got a mutation in that gene, or you've got that gene's not functioning particularly well, it's helpful for the cancer. And so what we know, whether the genetic change has been inherited, or whether the genetic change is within the cancer that has arisen in the cancer but not inherited, is having this gene not function particularly well promotes a more aggressive sort of cancer and a more aggressive behavior of the cancer. So as Andrei suggested, his oncologist was prompted to think about testing, in part because the oncologist noticed that there were some features about the cancer they didn't like, or they felt was, a bit more aggressive, whether it was a high Gleason score or some other features that made them think it's probably worth looking at this in a young patient who has an aggressive cancer. There may be something else that's driving it, whether it was inherited or acquired. So that's the first point to make about somatic, and we use the term somatic, meaning in the tumor. It has happened in the tumor, and inherited when actually it's been inherited. And it's the inherited one that has got implications potentially for family members, not always. So even if a father has prostate cancer and we find that he has got a inherited BRCA1 or BRCA2 mutation, he still only has a 50% chance of passing it on. So it's not a definite that he will pass on that gene to his children. But if he has it, then we would advise him to have a conversation with the children, and then they need to get tested as well. And as Will rightly pointed out, my view and the view of many of the patients I treat is, best to be armed with information, right? Best to have that information so that you can be proactive about the approach that you take with managing your care. But it's certainly something that raises anxiety and angst among patients. And I always confront that conversation before the test is done, because I would not like a situation where you do the test and the result comes back positive, and then you're having to address the implications about the impact to family members that the patient may or may not have thought about before. So I think it's important to talk about the implications, not for the individual in terms of informing good opportunities for other treatments, but also potentially what it means for a family member.
Well, I think so. And I mean, that's good advice. And of course, genetic testing generally too has this mythology now in the community about what it is and what it's used for. And everything we read about it is not always consistent, if you know what I mean. Not just about prostate cancer, but across the board. And I think it's about having those conversations based on knowledge. Like Will said before, knowledge is power. Based on knowledge and evidence, and having those conversations, between couples, within families, and of course more broadly in communities. Will and Andrei, I'm going to come to you in a minute for some, messages you'd like to leave for those people that are watching and listening to this video podcast, and to give you a bit of time to think about that, just to collect your thoughts. I'll come back to you, Shahneen, with it. So, we've had a terrific discussion, and it's encouraging to see the development. It's also, I think, a call to action with regard to what else needs to be done, and we recognise that. So, Shahneen, I mean, with your crystal ball, which I'm sure is a very wonderful thing, your crystal ball, with your crystal ball, can you just talk to us a little bit about, and what do you think the future might hold in this regard? In 5 or 10 years, where are we going? Are there breakthroughs that you're excited about, which are just around the corner? Are there things we should be looking forward to?
I think definitely, there's a lot. I'm not quite sure about my crystal ball vision, but definitely we've made a lot of progress. Not enough, but certainly made a lot of progress. And I envision maybe 5 years, maybe 8 years down the track, hopefully every man with a new diagnosis of prostate cancer will actually get their diagnosis in conjunction with a molecular test. Yeah. We do this now for lung cancer. We do this now for melanoma. We do this now for breast cancer and colorectal. It's just bread and butter. But we just, as a community, really have not gotten behind doing these sorts of things up front for men with prostate cancer. Why not know that you actually have some of these genes at the onset? Right? Why wait till, we know the data would suggest essentially sometimes the earlier you use these drugs, the better in the context of advanced disease. And I suspect in time we will learn to use these drugs, much earlier on in a more personalized way. So why not try to understand how to treat patients in a very personalized way from the onset, both from a perspective of informing their care, informing the care for their broader family. So that's my vision. 5 years, 8 years from now, genetic testing hopefully is going to be as cheap as chips, widely available. We'll start to understand a bit more about the different diseases depending on whether you've got this gene or this gene. And start to sort of personalize our approach for patients. And it's not just with PARP inhibitors, but there is data to suggest some cancers respond better to agents that target the androgen receptor versus other. So just becoming a bit more nuanced in our approach and not treating every patient the same way.
Shahneen, thank you. And you know what? I'm hoping, along with everyone else listening to this, that your crystal ball is spot on. So okay. We'll check. Let's hope that in 5 to 8 years, that's exactly where we are. Andrei, what about you? If we come to you, if you got what's your takeout on this for people listening and watching this video podcast?
Look, I was reflecting on this a couple of days ago. I was in a radio interview with Anne Savage, the CEO, on ABC Radio here, and a caller rang in on the topic of prostate cancer and described an enormous family history. His grandfather had it, his father died from it, he was diagnosed with it, his brother had it, his brother's daughter had breast cancer, and his brother's son had prostate cancer. So the obvious link there with genetics and genetic testing was quite apparent. And it just made me think, I guess people aren't aware of, what information they might be able to access to, I guess, make them safer in a health sense in terms of their actual risk. So I think, to me, we need to be heading in a direction of improving awareness in men, in families, about prostate cancer risk. And the genetic side of it is an enormously evolving area. We're understanding more and more about this. So, okay, we may only have one particular gene that we can target a therapy at the moment, but obviously that's going to expand over time. I think people need to be aware of the relevance of this, and they need to be able to have access to the gene testing, which is really pleasing to hear that's now happening. I was very lucky to access genetic testing by being in a study through the Peter MacCallum Institute. And part of that was, having the genetic testing done of my familial line. We don't want that disparity where people are having to pay lots of money to get tests done in other countries when everybody should be able to access that. We should have an equitable approach to that. So it's great to hear that is finally happening. So I think they're my thoughts. The next 5 to 8 years, this needs to be front and centre around diagnosis. It needs to be front and centre around informing people of their risks. So, for example, my dad, if he had had some form of genetic testing, if that had have come up with something, I would know even more about my risk, and that might have informed, my approach to, requesting a PSA test at a younger age, etc. So I think that's where we need to get to. where we're using this information to inform people about their risk. Obviously, the other side of it is the treatment side, which we've touched on.
Exactly right. Andrei, thanks for that. And thanks for doing that interview, by the way. I heard that it did go on and you had lots of callers. So that's
we had quite a bit of interest. It was quite engaging, actually. And they raised a bunch of questions which were prostate cancer myths, which Jan and I were able to address, which I think was quite helpful.
Oh, no, the feedback's been sensational. So thank you for that. Will, over to you.
Look, to wrap up, Andrei kind of touched on it then when he was talking about all the phone calls he got in that interview about questions. Ask questions. Anyone who is in this sphere, especially in the early phase of dealing with diagnosis, or they've got a family member who is going through treatment or diagnosis, ask questions of your doctor and doctors, because that's the way you get to find that extra knowledge. I was fortunate that it was all put in front of me that you should have this test and this genetic testing. I was lucky like that. But it was only because the doctors told me to get that done. Now I know, and I tell people, just ask lots of questions about all sorts of things. What else can I do? What else can I test for? So yeah, it's that scenario of don't leave any stone unturned is what I kind of recommend. And it's what I've gone through my whole treatment with. And I guess I always, no matter what we're talking about when it comes to prostate cancer, the thing that I always want everyone to remember, and it is a horrible disease and it has different side effects for different people, but it's that level of hope and support and love that is out there for you when you're not doing so well. The Prostate Cancer Foundation of Australia has wonderful telehealth nurses and nurses at treatment centres. Dealing with doctors and oncologists and getting bombarded with information can be really tricky. If you're not sure about it, please give the PCFA a call, and I know the nurses can break it down for you and just help guide you through it a bit too, because it is a confronting time. To make sure that you are getting, the best advice, the best testing, so that you can beat the disease as best as you possibly can and live a great life.
Hey, listen, thanks, Will. And, let's hope Alfie, Georgia and Emma, they take that advice and they live a great life too. Alfie, of course, is Will's son, and Georgie and Emma are Andrei's daughters. So, look, can I just thank our panelists who have highlighted a range of things for us today. They've explained for us in very clear terms some of the major issues around, genes and genomics and prostate cancer, highlighted some key issues about costs and about access, about the psychosocial impacts, which perhaps you don't think about, but really are very important, and how important it is to ask questions. I mean, those things remain critical, and all good advice. So in the end, it's about raising awareness, which this is about in part, understanding your own risk factors when you can, and talking to your general practitioner to make sure that you look out for your own prostate health and the health of your family. So can I ask you out there to join with me? I know we're not here physically, but to join with me in thanking Shahneen, Will and Andrei for this video podcast on genetics and prostate cancer. And finally, if you have any questions, if this discussion has raised any issues for us, as Andrei and Will have said, give the PCFA a call. The number for the telephone-based specialist nursing program is 1-800-2200-99. To say again, 1800-2200-99. Give them a call, and they'll be able to help you through that. And with that, ladies and gentlemen, thank you.